We'll continue with our prostate cancer scenarios discussion. Thank you for agreeing for the recording, which will be a good revision store. We will continue with the same patient presented with PSA. His histology has shown two cores positive for Gleason 6 prostate cancer. His MRI previously showed the areas which were targeted were PIRAD 3. The prostate volume is 60 cc, PSA density is 0.16. How are you going to proceed?
This patient would have been discussed at our MDT along with all of his imaging and his biopsy results. And I think as long as we were satisfied at the MDT that the biopsy is representative of the MRI target, then we'd have a discussion in the MDT about the options. This gentleman would probably fit into Cambridge Prognostic Group 1. Based on he had a low PSA, and he's got Gleason 6 disease, and it's organ confined, of course. So we'd, in the MDT, have an outcome for favouring active surveillance but offering all options. So I'd then see him in clinic along with the CNS and any family members that he'd want to be present as well to break the diagnosis to him. And I'd explain the MDT discussion following on from there. And I'd explain the options to him. I'd explain what active surveillance means and what the pros and cons are and what the idea behind it is. And I'd also talk about active treatment in the form of radical radiotherapy or radical prostatectomy, but say that active surveillance would be the recommended option as per the MDT. And we could talk a bit about the evidence behind that as well.
What is the evidence behind active surveillance?
Okay, so one of the main studies would be the CLOTS et al. Study from Canada. And that was a study looking at over about 10 years at patients who are under active surveillance. And the vast majority of them remained in active surveillance. About a third of them went on to active treatment. But crucially, over 98% of them the survival rate, was over 98% overall. So it showed that active surveillance was a very good or very safe option. And there have been many other studies locally. The Marsden have their own criteria, and they looked at their data over I forget the time frame, sorry, but again they showed very good safety outcomes, and it was very similar. About a third of them moved on to active treatment, but the majority of them stayed on active surveillance safely. I could also quote some of the PROTECT trial data because that's what some of the NICE guidance is based on within the tables. And I could say that the overall in prostate cancer in general, organ confined disease, there's no survival benefit that was demonstrated with active treatment. There was just a very small difference in terms of metastatic spread. But I would explain that he's in a very low risk category, so the risk of him progressing at this stage is very low.
So what is the regimen to follow as per the NICE guidelines for active surveillance?
So I'd want to do a PS for the first year. I want to do a PSA every 3 months, and I'd want to do a DRE at 1 year. I'd aim to do another MRI scan at up to 18 months at the latest. And then following on from that, I'd do a PSA every 6 months. I do a DRE once a year. Locally, we may consider doing an MRI actually once a year, and considering biopsies if there's any signs of progression.
Good. You are seeing this patient in the follow-up, and the PSA has jumped from 5.9 to 7.3. And as you know, is Gleason score 6 occupying 2 cores, PIRAD 3, like 60 cc prostate. So what is your next step? This is the first clinic appointment after starting the active surveillance.
Yeah, so his PSA has progressed. I'd want to, when I see him back in clinic, I'd want to re-examine him. I tell him that his PSA has gone up, and certainly his original PSA density was on the borderline high for significant cancer at 0.16. So it's certainly gone up since then. I would want to, before I go on, really just elucidate if there's any other potential causes for his PSA to go up. So, for example, has he had any recent infections? If there's no other reasons for his PSA to go up, I'd counsel him for reassessing things. So we may at this point consider doing another MRI scan and potentially further biopsies. I'd also explain to him that actually, even without any of this, the option for active treatment is always there should he just decide that he wants to do that. So even without restaging him, there is still the option to do that. The EAU guidance are more specific about needing to re-biopsy patients, but I don't think we have that in our NICE guidance.
Okay, so you are doing the MRI repeat, which showed PIRAD 4 lesions in the same area previously, which was PIRAD 3. So that shows some progression. And PSA density increased from 0.16 to 0.18. And you do repeat prostate biopsy, which showed again progression of Gleason score to 3+4. And it occupies 5 cores in the targets. So how are you going to proceed?
Yeah, so his PSA is still less than 10, but his Cambridge prognostic group now has jumped to 2 with his Gleason score. So I'd again discuss things in our MDT and see him back in clinic with the CNS with the results. The balance now goes actually for all options according to the NICE guidance for this Cambridge prognostic group. But practically speaking, we'd perhaps sway more towards active treatment in this situation. Looking at the number of cores he's got a higher percentage which are involved, and that would concern me. And we could also look at things like a maximum core length as well. But I'd have a further discussion about potentially going towards active treatment in this situation.
Any staging scans required at this stage?
No, his PSA is still less than 10. His Gleason is 3+4. So no, there are no further staging scans required.
Okay. And so patient is happy for some intervention. So how will you explain the intervention? What options you will give him?
So the options are, broadly speaking, radical radiotherapy or radical prostatectomy. There's also the option of brachytherapy, which could be done as a monotherapy or with boost, although you said his prostate 60 cc, so actually this probably wouldn't be an option, sorry, for him. I'll take that back. There are also focal therapy options, but those are only really in the context of clinical trials.
Okay, so what is the support you have or evidence for radical prostatectomy?
So there are 3 main trials. I've talked about the PROTECT trial already, so I won't go back over that. But the other 2 key trials would be the Scandinavian trials, so the SGPC trial, SGPC4 trial. So that was done in the era sort of in late 80s, early 90s, before PSA screening really was taken up. So there was a very high proportion of organ of T2 disease in that trial, but it was essentially randomizing patients between watchful waiting and radical prostatectomy. And they, in that group, they did find a difference in disease-free survival and overall survival. But again, they probably had a much higher proportion of higher risk prostate cancers in those groups. The other trial was the PIVOT trial, which was, again, it was more into the 90s, and that was as PSA screening was taking off. But that was done in America with the Veterans Association. So the patients that they were looking at were, largely speaking, of a lower socioeconomic class. Again, it was a similar trial looking at radical prostatectomy versus watchful waiting. And they didn't find much of a difference overall between the 2 groups in terms of overall survival, but the overall survival rates were much lower than you'd expect overall, largely because of the group, as I mentioned, that they chose had a lot of other comorbidities. What they did find was on subgroup analysis, specifically the intermediate risk cancer group did show a benefit in the active treatment arm. So it would advocate treatment in that group. And then lastly, there's the PROTECT trial, which, as I say, didn't show any difference in overall survival, but did show a difference in terms of metastasis-free survival in the active treatment arm.
Okay, so patient is convinced for radical prostatectomy. How will you sign him up?
Radical prostatectomy. So I'd explain that there are different approaches, open, laparoscopic, or robotic, and largely speaking nowadays the gold standard will be robotic, and it's what's done in our region. So I would talk to him about what that procedure involves. I'd say that it's minimally invasive keyhole surgery. In some places it could be done as a day case, but largely speaking, there's a one-night stay in hospital. I'd explain what it involves, which is essentially removing the prostate and then stitching the urethra and bladder neck back together. So I'd explain he'd have a catheter afterwards, which he'd go home with for about 10 days or so, which would be taken out after that. I'd explain what the risks are in terms of immediate, early, and late. The main ones I'd go over, immediate ones would be visceral injury, potentially requiring, if there's a bowel injury, a stoma, or major vascular injury. Early complications, including infection, bleeding requiring return to theatre, and later complications in terms of his continence and in terms of his sexual function, erectile function, and ejaculation, and of course the risk of biochemical or clinical recurrence needing further treatment. I'd quote some figures really regarding his functional outcomes. So it depends whether we're going to be able to nerve spare him, and we've had that discussion in MDT. But it'd be between 40 and 60% would have erectile dysfunction. And in terms of his continence, I'd say to expect incontinence afterwards in about 50% of people. At a year, that number then goes down to about 5 to 10%, and less than 5% will actually need surgery for incontinence that's really severely affecting them. I'd also just lastly talk about how we prepare them. So I'd explain about pelvic floor exercises, and I'd touch on potential PD5 inhibitors, and I'd give him some BAUS information leaflets and CNS details.
Yeah, you can bring in BAUS information leaflet even for the active surveillance, which we discussed in the last scenario.
Yeah.
And bring that you are going to do the procedure by robotic assisted laparoscopic prostatectomy. That will be the gold standard nowadays.
Okay.
Is there any role for neoadjuvant treatment prior to radical prostatectomy?
No, there isn't. The evidence is that although it potentially can downstage prostate cancer, so you'll find less nodal, less T3 disease, but it doesn't have any effect in terms of overall survival, so it's not advocated. Okay.
What is the evidence between robotic vs lap vs open? How will you choose robotic if available?
I can't quote a specific study, but the advantage of minimally invasive treatment, so robotic, is in terms of hospital stay, and in terms of recovery, and in terms of wound complications and pain post-operatively. But I can't quote a specific study.
Yeah. So how will you decide about lymph node dissection?
So again, that's probably a controversial area. I'll explain to the patient that lymph node dissection doesn't improve survival, but it can be useful for prognostic purposes. In practice, what we normally do is use a normogram. Which one we use depends on how the biopsies were done. So if we've done MRI targeted biopsies, we'd use a newer Briganti 2018 or later normogram. But if it's a systematic biopsy, we could use MSKCC or even an older Briganti normogram. And the cutoffs, if it's a targeted biopsy using a newer one, it's about 7% in terms of lymph node risk, and above would warrant a lymph node dissection potentially. For the older ones, it'd be 5% for systematic biopsies. And yeah, that's how we decide on whether we do it or not.
How will you decide about for example, when the nomogram shows you like 5% chances or less, you don't have to do the lymph node dissection. But if you did the MRI guided biopsy, you can make the 5% into 7%, as you said. And there is no role for any frozen section when you're doing lymph node dissection. So predominantly, it is restricted only for the high risk groups. Any questions you have on this radical prostatectomy before we complete this scenario?
Just one thing. What should I quote when I'm asked about the evidence for robotic versus open?
There is no real big evidence other than a Cochrane review which compared radical prostatectomy with robotic assisted, laparoscopic assisted, and open assisted. And the Cochrane review included two randomized controlled trials. And as you said, there is no differences between the oncological outcome, urinary or sexual function outcome. But in robotic assisted group and also laparoscopic group, there is statistical significant improvement in the duration of hospital stay, blood transfusion rate compared to the open group. And there is no way you can advise one surgical approach over the other. But if you have robotic, it's always nice to advise robotic because of the less hospital stay. A lot of people say open is always advisable when you do lymph node resection because that gives better access and better wider clearance of lymph node. That's only for the high risk patients.
Okay.
Okay, good. We'll stop now.
Okay.